And transplant, and he's my contemporary, and he's skilled in nephrology, especially hope to get a lot of information from his case to come. And Dr. Shaktiram is also an associate consultant in Apollo, and he's going to present the case and welcome you, sir, for this meeting. And the second case is going to be presented by Dr. Manjari Bhatt. He's a resident in Manipal Hospital doing nephrology DRNB, and she will be ably assisted by Dr. Rohan. I am afraid that Rohan is not here because of this Easter is on the way, and they might be busy with the church meetings. And he will be assisted by another consultant, and hopefully, and this will be the case of adenovirus nephropathy, and this is also a very tricky and important case to discuss, and we expect a lot of things to take home from this case too also. So welcoming all delegates for this meeting, and without wasting much of the time, I direct to Dr. Shaktiram to present his first case of from 20 years of dialysis to transplant time in HUS. Over to Dr. Shaktiram.
Thank you, sir. Thank you, sir. Good evening, everyone, and good evening, respected panelists. And moving to the case report. This is a. Am I audible, sir? Please.
Yeah.
Okay. Slides are visible, sir?
Yeah. Go ahead. Okay, make it a full screen.
Yeah. It's in the full screen, sir.
Yeah. Okay.
So it's from 20 years of dialysis to a transplant type in an atypical HUS patient. Moving to the case report. So the case history goes like this. The patient at the age of 14 years in the year of 2006 initially had a history of fever for 5 days, for which he took some NSAIDs and it subsided actually. Subsequently, in the next couple of days, he developed multiple episodes of loose stools, for which he was warranted admission. He was admitted and evaluated at Bangalore. At the admission itself, he was found to have a creatinine of around 14 milligrams. And also he had a severe anemia with hemoglobin of 6 grams at that time. And at that time, he was started on hemodialysis support. And subsequently underwent a renal biopsy. He was initially diagnosed as an AKI, and he was managed like that, and he was underwent a renal biopsy. And this was the renal biopsy report that was available to the patient, and it showed features which was consistent with the TMA with evidence of tubular and focal cortical necrosis. And based on this biopsy report, he was started on steroids at that time, and also he was considered for a plasmapheresis. And he was given 8 sessions of plasmapheresis. And the 8th session, he developed some allergic reactions, so the plasma was stopped. And he remembers his creatinine to be around 3 milligram post 8 sessions of plasmapheresis. And then he was followed up subsequently. Subsequently, over a 3-month period, his creatinine slowly crept up to 9 to 10 milligrams. And when the creatinine went to 10 milligrams, he was started on maintenance hemodialysis. And he was on maintenance dialysis since 2007 January through IJV temporary access, followed by a left BC fistula access. So he was diagnosed in 2006, and in 2007, he was started on maintenance hemodialysis. So he for the next 10 years, he was on the maintenance hemodialysis. In 2017, he was planned for a renal transplant. When he was planned for a renal transplant, he was anticipating his basic disease to be TMA. He was subsequently subjected to 2 tests, one genetic testing and anti-factor H. The initial genetic testing which was done showed deletions, homozygous deletions in the R1 and the R3 gene. And this anti-factor H levels was 58.78 at that time, with the reference range of 0 to 20 AU per ml. When he was initiated for a transplant workup, there was some initial hiccups was seen in the donor selection, availability of the eculizumab drug, and he had a high anti-factor H antibody levels, which was present at that time. His genetic workup, study was even confirmed in another lab. In another lab, which also showed a homozygous deletion of factor R3 and R1 with exons at 1, 2, 3, 6 and intron 4, and exons 2, 4, 5, 6 and intron 1, 3 of the respective R3 and the R1 levels. So his genetic workup was confirmed with another lab also. So this was the stated 2017 when he was planned for an initial transplant. And subsequently, his anti-factor H antibody levels was evaluated subsequently over the course of years, which it normalized over the course of next 2 years, where it went to 13.75 in the year 2019 And in the year 2021, it was 85.5, but the reference range varied in the two studies. It was 0 to 100 and 0 to 100 respectively in the two. So with all this background, he was planned for a renal transplant in the year 2024 with his cousin as his donor. His pre-transplant atypical HAS evaluation, once again, we did anti-factor H levels, which was within the normal range of 65 AU per ml. And his initial baseline CDC and flow cross-match was negative. And we actually planned to do transplant in the year 2024 with eculizumab as a backup. We arranged for eculizumab and we were about to proceed with the transplant. But what fate determined was few days before the transplant, he had an AV fistula rupture due to a pseudoaneurysm, and he presented with shock to us at emergency, for which we had to resuscitate with multiple blood products, and the fistula ligation was done. Subsequently, a left IJV temporal line followed by a tunnel catheter was placed, anticipating transplant in the next few months. In the month of June, when we repeated the cross-match for the transplant, the CDC turned out to be strongly positive. We presumed this to be because of the multiple blood products which he received because of the fistula rupture. His CDC was positive. We repeated a flow at that time. The flow was also strongly positive at that time. So both CDC and flow positive, we canceled the idea of proceeding with the transplant, and we did a DSA for him at that time. So the DSA showed a PRA of around 17%. Here I have attached the donor HLA for reference. It was that class 2 DSA was negative. It was class 1 DSA which was positive. PRA was 17%. He had two donor-specific antibodies. At A0201, it was of the titers of 15,240, and in the B, it was 57.01, which was 3,052, which was the titer level at that time. So because it was due to a prior history of blood transfusion, we waited it out over the next few months. In the next few months, there was a decrease in the titer of the antibody titers over the next few months in the DSA, which we used for monitoring his class 1 titers. But a meaningful response was seen in the next subsequent year, in July 2025, when this B antibody titers against 5701 disappeared, and the A titers reached a lower of around 1,000 to 1,855 ml. So anticipating further decrease in his PRA also decreased to 6% from 17% in the June 2024, it decreased to 6%. So anticipating a further decrease in titers, we waited for 3 more months. In the month of September, we repeated a cross-match with the same donor. His CDC was negative, but the flow was positive at that time. We repeated a DSA, which was once again positive, and the titers was 1,805. At this time, we had two options, either to change the donor and look for other donor. Maybe he might not have a DSA, or to wait it out for the next few months till the DSA becomes negative. We did actually both the options. He turned out to be positive with other donors also, so we couldn't go with that options. So we had to wait it out for the DSA for the titers to fall. So we started him on a low dose of immunosuppression. CellCept was started at that time, anticipating a decrease in the titers in subsequent time period, so that the transplant can be proceeded. So this was in the month of September. So in the month of December, there was a decrease in the DSA titers to 1,055, the A0201, but it was still positive. And there was virtual cross-match report which was given to be positive for positive against the donor. And luckily, in the month of January, after starting the CellCept around 3 or 4 months, in the month of January, the DSA titers became negative, and it reached 581, and there was no donor-specific antibodies. His PRA was 0%. For class 2, always it has been 0%. For class 1, it touched 0% in the month of January. And on this background, we went for we decided to go ahead with the transplant, and we did a CDC and the flow cross-match before the transplant, which was also negative. And we determined the anti-HS antibody levels, which was also within the range. With a low risk of transplant, we decided to proceed with the transplant. This was the transplant protocol we followed for this patient. On the day -7, we started him on immunosuppression with the Tacro and MMF, and we sent the final cross-match, which was negative on day -1. We also gave injection rituximab on day -1. So keeping in mind the DSA, and he had a low risk in the form of homozygosity, we don't want any rise in antibody titers in the post-transplant, especially in the immediate period, which could trigger a rejection, which can even trigger a TMA in low risk patients. So keeping this in mind, we gave rituximab that can suppress both the anti-factor H antibody levels as well as the DSA titers. So with this rituximab of 200 milligram, we just went ahead with the transplant. On the day of transplant, we used the ATG as induction agent to a dose of 1.5 milligram per kg. The cumulative ATG dose which was given was 2.5 over the next 3 days. And first dose of eculizumab was given few hours before the surgery. We gave a dose of 900 milligram, and HTK solution was used for the perfusion. Post-transplant events, initially the patient had brisk diuresis with no major complications. He was monitored for daily evidence of peripheral hemolysis with the CBC, creatinine, peripheral smear, and the creatinine touched baseline on POD3. On day 3 also we sent a DSA which was negative for class 1 antibodies, thereby confirming that the titers are still in the negative. And serum LDH was repeated and it was normal. And the complement levels was checked on day 5 and it was normal. He was on discharge on day 7 with a normal renal function. We intentionally plan to keep TAC levels around 6 milligram in the initial post-transplant period based on few observational studies which showed low TAC levels helps in preventing the early atypical HOS recurrence in the transplant. And we gave a second dose of rituximab of eculizumab of 900 milligram on the day of discharge on day 7. And we continued antibiotic prophylaxis against meningococcal, which was given in the admission period and over the review period, at least for a month, was given. So this is his post-transplant investigations. His hemoglobin was daily followed. It was around same. There was no major fall. His platelets improved over the course of transplant. His creatinine touched baseline on day 3 of 0.8 and continued to be around the same for the next term till discharge. His LDH was normal and the complement levels was normal. His initial TAC levels was high and we adjusted a dose accordingly. This was at the 2 weeks and at the 4-week follow-up. And this was at the 2 weeks and at the 4 weeks follow-up. And this 2 weeks, 4 weeks, the TAC level was maintained around 6. His LDH and C3, C4 was normal. Creatinine was maintaining. Everything is going smoothly. And currently, it's at 6 weeks post-transplant of the following immunosuppression dose with program of 2 mg, cells of 1 gram, and Visalon of 20 milligram. So moving to the discussion part. So discussion part is approximately 60 to 70% of patients who are having atypical HOS can have an inherited or acquired dysregulation of the complement pathway. The inherited dysregulation can be either a loss of function mutations in a regulatory protein like complement factor HI46, or it could be a gain of function in gene activating proteins like C3 and factor B. For any patient who are having atypical HOS with a genetic background, to have a clinical manifestation, we need an environmental trigger. In our case, he had history of fever, multiple episodes of loose stools, which can trigger a TMA on a background of a genetic homozygous deletion of factor R1 and R3. When we transplant these group of patients who have a strong genetic background of atypical HOS, the risk of recurrence is very high, between 50 to 80%, which depends upon the type of mutation he incurs, and also the graft loss is pretty much very high. So we have to be very careful with these group of patients with high graft loss and high recurrence rate, and we need extra care in these patients rather than a normal transplant patients. So what is the first precaution we need to take is, we need to understand what these patients belong to, where they belong to, whether they belong to a low risk of recurrence or a medium risk of recurrence or a high risk of recurrence. This is based upon their genetic, what they inherit as a genetic defect. Say a mutation in CD46 comes under lower recurrence, whereas a mutation in factor H or any gene arrangements of between factor H and factor H regulatory proteins come under high risk. Similarly, gain of function of mutations in factor B or C3 also comes under high risk. Any loss of previous transplant comes under high risk. Whereas your factor I mutation, variants of unknown, uncertain significance, autoantibodies against factor H. When the antibodies was, in our case, the antibodies in the initial was detected against the factor H, so it came under medium risk. But subsequently, because of being persistently negative, it comes under low risk. So autoantibodies against factor H or any mutations of factor I, and or we are not able to identify mutation in a person with the TMA. These all comes under, with the strong genetic background, comes under medium risk of recurrence. The risk stratification is very important because when we discuss for a patient, for a transplant for a patient with TMA, there are some questions that comes to us. One is, who can be an ideal donor for this patient, cadaver or a living donor? Do we even consider a living donor in a patient with atypical HOS? And in the era of eculizumab, whom should be given eculizumab? And how long to consider eculizumab? So this risk stratification plays a major role in giving answers to these questions, actually. The first question is, who can be ideal donor for a patient with atypical HUS? See, this was a study that was retrospectively evaluated in the year 2003 to 13, 12 patients who had atypical HUS, underwent transplantation following atypical HUS. It included 4 child patients and 8 patients were lost the prior transplant due to atypical HUS. So 12 patients was there. Of these, 9 patients received a living related donor transplant, 3 received a cadaver transplant. Out of these 9, 4 received eculizumab prophylaxis, 5 did not receive prophylaxis. Out of these 5, 2 had a recurrence. But when we see in the cadaver, almost 3 patients received without any prophylactic eculizumab, and all 3 patients had recurrent and early transplant failure was seen in all the 3 patients. Whereas here, some graft was salvaged in the living transplant patient. On this finding support that in patients with atypical HUS, outcome may be more favorable in case of living donor transplant patients. So how this statement is relevant is that, as we know, the genetic predisposition to atypical HUS, in order to have a atypical HUS to manifest, we need triggers. The triggers can be infection, triggers can be rejection, triggers can be endothelial damage, triggers can be uncontrolled hypertension. In whatever may be the trigger, the atypical, it can manifest as a TMA. But in cadaveric transplant, because of its inherent nature, the infection risk, the rejection risk, endothelial injury, everything is more increased. Whereas in living renal transplant, we are able to have a controlled environment where we can have a control over these factors. So maybe the living can be a good transplant option for patient with atypical HUS, provided the living donor is screened adequately for any genetic abnormality in themselves. Especially in the era of eculizumab, living donor can be considered because they have some advantages over the cadaveric donors. So this is the first question, who can be ideal donor? The second question is, when to give eculizumab, how long to give eculizumab? So the KDIGO guidelines in 2016 has advised to give a prophylactic therapy of eculizumab for transplant patients who are considered medium to high risk. As we have seen, for any patient to get a transplant done with atypical HUS, first we have to risk stratify them, whether they belong to medium or high risk or low risk. For medium to high risk patient, they advise the prophylactic therapy. They also recommend to continue eculizumab. This is what they say. These recommendations comes and also has some clinical evidence. Comes from various clinical evidence. So this was a UK cohort study, which was studied. It was a retrospective cohort study, which was studied, which took 70 patients. In these 70 patients, 38 patients was in the prophylactic treatment cohort, and 32 patients was in the control cohort. What is prophylactic treatment cohort is they get eculizumab before the transplant itself to prevent atypical HUS recurrence. 38 patients was like that transplanted. All 32 patients was transplanted without eculizumab. All these 70 patients were having either a medium or high risk for a atypical HUS recurrence. So this was at the 1 year data. This was the outcomes which were seen. In the control arm, the functioning graft at the end of 1 year was only 11. The failed graft was 22. Among the failed graft, post-transplant TMA recurrence was seen in 14 of the graft. This was in the control cohort, which did not receive any eculizumab, where the graft loss percentage was around 42%. Whereas in the prophylactic eculizumab cohort, the functioning graft, total functioning graft was 31, but the graft loss to TMA was only 1. So this is a graphical representation of the above tabular column, which shows 70 patients with medium to high risk. And these patients received eculizumab or no eculizumab. The 1 year survival rate was 97 with eculizumab and 64 without eculizumab. Based on this, prophylactic eculizumab improves the survival in patients with medium and high risk of atypical HUS recurrence, which was given by the KDIGO. So this is a graph that shows a long-term follow-up of this group of patients. If you say this group of patients, when they are followed up for over 7 years, there is a clear difference in the graph between those who are treated with eculizumab or those who are the control group who did not treat with the eculizumab. There was a clear difference in the graft outcome even after 7 years. And this is 2 graphs that shows the renal graft survival in patients with eculizumab based on the risk stratification on the right, based on the mutations on the left. What it says is that the red line is the patients with high risk group. They have a very low graft survival. The blue is the medium risk and the black one is the low risk. Similarly, on the other side, we see the red being the factor H mutation, which has the lowest risk of survival. Above is the factor B. The yellow, purple, and this will be the medium group. This includes yellow will be B variant of unknown significance, and the purple will be the anti-factor H antibody being positive, and the top one being the CD46, and the orange one being the factor I, which belongs to the medium risk. So the red and blue are high risk, and the middle three are the medium risk. The top one is the low risk. So the renal graft function improves as the risk reduces. So these are the graphical representation of this. So based on this, they concluded that initiating eculizumab treatment prophylactically for medium to high risk patients enhances the graft survival. They also recommend prophylactic rather than reactive at the time of atypical HUS recurrence. So what is reactive? Reactive is a thing where we give eculizumab when the patient has a recurrence. Here, prophylactic, we give whether the patient has a recurrence or did not have a recurrence, we give eculizumab routinely to all patients at a fixed interval of time. Whereas in reactive, they give only when they have a atypical HUS. This was predominantly followed by Dutch, which will be discussed subsequently. But this group felt that a concern with treating these patients at the time of recurrences, there can be a delay in eculizumab initiation. There can be a delay in diagnosis. The delay in because initially when the transplant is there, patients will come regularly. But late TMA recurrence can be missed when you go for a reactive eculizumab. Similarly, when you give eculizumab early in the process of TMA, the response has been documented to be much better than we give late. So this study at the end of 9-year follow-up, 61 out of the 71 failed actually. 41 had post-transplant TMA. Because of post-transplant TMA it failed, and highest was in patients with factor H deficiencies. This was the UK cohort study which gave the evidence. This is a Spanish registry of atypical HUS. It was also a retrospective cohort study. Here they included 36 patients, where there was 14 patients who had a diagnosis of atypical HUS at the time of transplant, where they had 22 patients who had a de novo TMA after transplant. So these were the results. So 14 patients had a native kidney disease of TMA with a genetic risk moderate of 6 patients and high genetic risk in 8 patients. So this was the 14 patients. In these patients, 9 patients received eculizumab. There was no graft loss, and they were able to wean off eculizumab in 2 patients with moderate risk at 2nd month and 1 year respectively. This was the 9 patients study. 5 patients in the PREEMPT-2 who were not treated, they record 3 patients recurred, and they had to treat, and 1 had a graft loss. This was a native TMA where they had a clear genetic risk. This was how it was there. Whereas in the de novo TMA is a TMA that occurs after the transplant. That was seen in 22 patients. All were cadaveric patients who received different type of donors, DBD, DCD, different high-risk type of donors also. In these patients, when they did the genetic study, 4 patients had a low genetic risk. Here they divide into 2 groups. One is the early TMA, the other one is the late TMA. So when a post-transplant TMA occurs within the first month, they call it early. After 1 month, they call it late. So 16 patients had an early TMA, in which plasmapheresis recovery of renal function was seen in 4 patients. Eculizumab as initial treatment and rescue was given in 11 patients, and 10 patients had a good graft recovery. The time to initiation was 11 days. This is important, I'll say like. The late patients were 6 patients. They all received plasma and eculizumab. But here the eculizumab was initiated after a median time of 27 days. And the graft loss was 3 out of 6, and recovery was seen in 3 patients. The difference between early and late is the time to initiation of eculizumab. The time to initiate eculizumab was 27 days in the late. So there was more graft loss, whereas they had a better recovery of renal function when it was initiated early. And also all these patients had a very low genetic risk. So predominantly these patients were secondary TMA patients. So they were able to withdraw eculizumab in all these patients with de novo TMA, predominantly due to secondary TMA. And also this shows that in secondary TMA also, when the plasmapheresis fails, eculizumab can be used as a rescue therapy. That's the thing. So moving from prophylactic, we go to the next thing, which is called as the rescue eculizumab. This was predominantly followed by a Dutch group. What they felt was they had a transplantation protocol where they could prevent the recurrence of the TMA in the early post-transplant period. So this was around, they studied a 17 group of patients with a genetic risk of atypical HUS. Here they included 8 patients with pathogenic variant in C3 and 8 patients in factor H and I, all belong to medium to high risk of atypical HUS recurrence. In these 16 patients, what they did was they had a transplantation protocol They had an induction therapy with basiliximab 20 milligram on 0 and 4. Low dose CNA that targeted a CNA of 4 to 6 in the first month, later around 6 to 7. They had a MMF targeted to 2 grams with 2 grams with a high area under the curve. They strictly controlled the blood pressure less than 130/90 and prevented all triggers that can cause endothelial injury. In this group of patients, when they followed this transplantation protocol, they followed up for a very short period of over a year. They found that only one patient had an atypical recur, for which they gave eculizumab as a reactive therapy. So only when the HOS recurred, they gave the eculizumab, which also promptly improved the renal function. But this study was very short period of time, was this study. So based on a follow-up of this study, they did what is called as the cure HOS study in the transplant patients. So this is a Netherlands prospective study, which once again studied from January 2016 to 20. All these patients had an induction similar to the protocol was similar to what they used in the rescue eculizumab Dutch group. So they gave the same induction therapy. They monitor for the atypical HOS recurrence, of which 15 patients had a atypical HOS recurrence. After kidney transplant, all these patients received eculizumab as a rescue therapy. After they receive eculizumab as rescue therapy, over the next 3 months, if they have a stable graft function, they will be weaned off from the eculizumab over the course of time. So this was how they were planned to make the study. Once again, here they split the group into 2 groups. One is the early HOS within first 1 year. One is the late HOS. So out of these 15 patients, 7 patients had an early HOS. These 7 patients, out of these 7 patients, there were some triggers, and also there are various triggers like CNA toxicity and other things. There are various triggers were there in this 7 group of patients. In this 7 group of patients, and 5 had a good recovery. 5 had a good recovery. And in the late HOS patients, almost all the patients had a good recovery. Almost 13 out of the 15 patients had a good renal recovery, which they say recovery of the graft function once they started eculizumab. This was the initial period, but when they followed up over a period of for 29 months, they found that the graft loss was seen in 3 patients, and the deterioration of graft was seen to less than 30 ml was seen in another 3 patients. So what is that? At the end of the follow-up of 29 months, 3 patients lost their graft, even though the initial response was good, where they had around 13 out of 15 patients responded. At the end of the follow-up, 3 patients lost their graft. Another 3 patients experienced severe loss of GFR after eculizumab withdrawal. In most patients, progressive kidney injury was attributed to early withdrawal of the eculizumab. So 3 patients graft loss, 3 patients had a loss of GFR, and the progressive kidney injury was documented because of early withdrawal of the eculizumab in this group of patients. Here they targeted these 5/8 patients. These 5/8 patients who presented with a slow decrease in GFR were a group of patients. These group of patients were nothing but they had a slow TMA. They had a renal limited TMA. And there was no evidence of any systemic TMA in these patients. They had a slow creep in the creatinine. When these group of patients, when they stopped the eculizumab, they had a slow creep of creatinine. When they reintroduced eculizumab, they are able to maintain the GFR in this group of patients. The importance is that TMA can present as a cumulative effect also over the course of time. So when we give eculizumab, the TMA is come. Sometimes it can accumulate over the next few years. The TMA effect can be accumulated on a background of a genetic risk. And if you don't have aggressive biopsy, we can miss these patients, and they can end up being diagnosed as a chronic TMA. At that time, even when they initiate eculizumab, they may not recover the renal function. So this was how they concluded that even though the data are limited, eculizumab withdrawal is associated with a higher relapse rate after kidney transplantation when compared with the native kidney. When compared native kidney in transplant patients, eculizumab withdrawal can be associated with the relapse rate, and also it can be associated with the deterioration of the kidney function. So to just summarize what, yes, sir.
Make it short and crisp. Actually, you are exceeding the time.
So to make it to conclude, the living donor can also have better outcomes in atypical HOS. Prophylactic eculizumab in moderate high risk has good outcomes. Rescue eculizumab, which we use, has its limitations. Withdrawal of eculizumab carries risk of graft deterioration. Secondary causes of TMA not responding to may warrant eculizumab therapy. So this is what to summarize whatever we have discussed. And just for 5 minutes, if I have time, sir, I can just discuss the 2 things also, sir.
Okay, fast, quick, please.
Yes, sir. So this was a case 2, which we have increasing case, where this also case was similar to the first case. This case also, it's a 48-year-old man who presented with fever in the year 2022 for 5 days, and he had peripheral hemolysis with RPRF, low complement levels, autoimmune tropical fever, Adams 13 was negative. He dialyzed and underwent renal biopsy, and the biopsy was TMA, plasma steroids, no improvement, and he is becoming dialysis dependent. So this is his genetic study report, where he had a complement factor I mutation, which was heterozygous mutation in CN. This was the C2C tyrosine to histidine. There was the heterozygous genetic mutation. This is the case 2. And the case 3 is interesting. It's a 26-year female who underwent liver transplant with father as a donor in the year 2019. The native kidney disease is not known. The creatinine CIN presumed. It was 0.9 at discharge. So timeline event, initially she was anxious to conceive. She was changed to Azuran. Subsequently, she developed a graft dysfunction at 1 year, 2 months post-transplant. And it was treated and creatinine settled around 1.5 milligram. And in April, in 1 year, 6 months, this is important because she had recurrent episode of loose stools. Following this loose stools, in July 2021, she had a graft dysfunction with peripheral hemolysis. And she was started on empirical plasmapheresis with plasma and hematological parameters resolved, but renal failure settled around, it went up to 4.3 and came down to 1.9. At this time, tacrolimus was switched to sirolimus and Azuran with Vislon. The creatinine was maintained at 1.8. Tacro was also contributing to TMR. We stopped the tacrolimus. And the tacro was reintroduced 6 months later. And she maintained a good graft function till 6 years post-transplant. But 6 years, once again, she developed a graft dysfunction. This time, the biopsy showed a chronic TMA. And features of also ABMO was seen, also with chronic TMA, but the DSA and C4D was negative. And this time, the creatinine said 3 milligrams when she was treated with plasma and rituximab. So this was the biopsy report, which showed a chronic TMA at 6 years post-transplant. And she had a TMA at 2 years, July 2021, 1 year, 6 months post-transplant also. And she developed pneumonia post-treatment with rituximab. And currently, her creatinine is only 6.5. She is managed she was planning for a ESRD treatment. So this is her genetic report. She had only a heterozygous deletion of the R1 and R3 on the background of a TMA. So the points of discussion can be that the case 1 warrant extra dose of eculizumab, having known it's a very low risk. Now we can confidently say that we can stop with eculizumab, but could eculizumab have been avoided in case 1 is a question that we would like to discuss. And with regards to the case 2, in the factor I deficiency, which comes under medium rust, how long eculizumab will need to be administered in this clinical situation? The clinical experience of this various members would be helpful in this regard. In the case 3, we find that triggers for TMA to be an infection, loose stools, which was seen, tacrolimus, and at the 6 years, it was an ABMR, DSA, and C4D negative on a background of a heterozygous deletion. The immunosuppressive choice in the next transplant, whether to reintroduce tacrolimus or not, and need for eculizumab, because this time we didn't give any eculizumab. Maybe in the second transplant, even if it's a secondary cause of TMA, can we try eculizumab in this patient will also be a point of discussion. Thank you.
Thank you, Dr. Shaktiram, for the exhaustive lecture on atypical HUAs and all. And Dr. Venkatesh Rajkumar, do you want to add anything shortly, please, because we are running short of time, and we can ask comments from the panelists.
Yes, sir. He has almost told everything, Dr. Rajan. It's open. We can go ahead and discuss it.
Okay, Dr. Narayan Prasad, sir, your comments, please. Dr. Shaktiram, you just unscreen your unshare your slides, please.
Okay.
Dr. Narayan Prasad.
Yes.
Yes.
No, I have only few comments. Most of the times, factor H antibody, anti-factor H antibody, which is produced usually autoimmune phenomenon, and this group of the patients do well. So really, when you have any heterozygous or when you have MLPA done, and this probe to peak ratio is if within the normal range, or if it is above the 50%, then there is no need of using eculizumab. And in that group of the patients, you can go without using eculizumab, keep for the rescue. If any problem comes in, then you can give. or otherwise you can safely go without using eculizumab, and this autoantibody phenomenon is well controlled by any immunosuppressions. So recently we have done one transplantation, whether the patient, similar to your case 3, the patient has got a transplant somewhere else, came with some complications to us. We have biopsy, TMA kind of things were there, tacrolimus toxicity was also there. Subsequently, we have studied then the CFHR1 and 3 mutations, which is very common in our parts of the world, even in the general populations. You can see this mutation can be present normally. So MLPA estimations sometimes becomes very important, we can see. And subsequently, what we have got this patient transplantation done without using eculizumab. We have kept for the rescue, and the patient underwent well. So sometimes we can go with the heterozygous mutation, particularly if this is there and MLPA level is above the 50%, then we can go without. If homozygous mutations, very zero MLPA, then definitely we should give eculizumab and then go for that. So that is the one thing I want to say.
Rajarajan, one question, in fact, to Dr. Ranaprasan, sir. Sir, this
Yes.
girl, the third case in discussion, we do not know the basic disease. We could not do a biopsy, but she had a clear-cut episode of systemic as well as kidney-related TMA in the second year post-transplant, where she had loose stools, a proper anemia, thrombocytopenia, and renal failure, which improved with plasmapheresis. The creatinine settled around 1.8, and now we could do a biopsy and prove a chronic TMA. And though there are features of ABMR, C4D is negative, DAC is negative. So I'm inclined to think more in terms of TMA rather than an antibiotic rejection. Taking such things into consideration, though she has got a heterozygous deletion, where we have seen her developing TMA on 2 separate occasions and proven it in the biopsy also, don't you think that comes automatically under high risk, and should we use the drug rather than to take a chance?
Yeah, definitely. The major confusion in such group of the patient is really a typical HUS, or it is a secondary to your ABMR or some ongoing CABMR kind of situations. As far as the C4D is concerned, when you look at the spectrum of the CABMR, at one point of the time, you might not have, when what is called a escalosing CABMR. One is very active CABMR, where you will have the peritubular capillaritis, you will have the C4D positivity, but other spectrums when comes, then even peritubular capillaritis disappears. And you might not have any evidence of the C4D positivity at that time also. So this is not the conditions that you cannot say this is not antibody mediated rejections and other spectrums. So histologically it is proven. When you read 2019 BAMS classifications, this spectrum has been described. So always finding in advanced stages and long-term ongoing antibody mediated rejections, chronic active particularly, it is not always you will see C4D positivity. You will always not see the peritubular capillaritis. It might be the other variants, and so all it depends on the chronicity of these conditions. Chronic TMA in such group of the patient may be because of the tacrolimus, or maybe because of the ongoing antibody mediated rejections going on and had some evidences of the TMA. Really, recurrence of the TMA atypical HUS usually do not behave like this. You cannot go without, if recurrence is there, it will be very severe, you will have the other problems. So I think, and the way the patient has been rescued, it looks like more of either the drug induced, or more or likely it might be chronic active antibody mediated rejections, which is going towards this chronicity. So chronic sclerosing kind of the antibody mediated rejections can be there.
Thank you. Thank you, sir. We don't have much time to go. Dr. Pani, your comments, please.
I think it's a nice presentation. A couple of comments are, I'm more worried about HL incompatibility rather than atypical HUS as a significant risk factor for this patient, because the patient was positive for both cross-match, flow and CDC cross-match earlier, and also virtual cross-match. I mean, thankfully, you have waited long enough for these levels and titers to come down. But still, we always have to be wary of a recurrence in the context of memory cells coming back and attacking the kidney. So with regards to the atypical HUS, I think this is a low risk, and I completely concur with Dr. Narayan Prasad to say that the eculizumab role may be very limited or may not be needed at this point, given that the titers have been well within normal limits. One thing I just want to clarify is the CFHR1 to 3 heterozygous gene deletions. So what we know is anti-CFH antibodies are likely to be present only in homozygous. That's a slightly overstatement. Or likely to be associated with homozygous deletion is just because the CFH as well as the complement factor H are 1 to 5 are very structurally similar. And when there is a deletion of CFHR1 or 3, the immune system somehow does not see or somehow sees factor H as a foreign antigen and starts making antibodies against this. And hence, the chances of someone developing an antibody in the context of a heterozygous gene deletion is extremely low. And it's a matter of fact that almost 30 to 40% of the Indian population do have a heterozygous gene deletion. And hence, that may not be a significant in your third case. That's my feeling. But saying that all patients with factor H R1 to 3 gene deletions may not develop antibodies. Similarly, all patients with anti-CFH antibodies may not have the same gene deletions. So that's just a point to clarify.
Thank you. Thank you, Doctor.
What was this MLPA in the first case? That has to.
It's a homozygous deletions in CFHR1 and 5.
Okay.
So one quick point I want to make to the audience is, if we are going to use eculizumab, we should ensure that they're all vaccinated at least 2 to 4 weeks before giving eculizumab.
You got to vaccinate it against meningococcus and other things. It's very interesting. Yeah. So, sorry, sir. One last question. This factor CFHR1 and 3 related HUS, can they happen? I understood you said that, but still, can they happen even in the absence of factor H antibodies? Or is that the only mechanism? Yes.
So it is not always that you have the antibody. Sometimes a deficiency can have the antibody, and this can happen without antibody formation.
In that case, that traditionally comes under
if antibody formation is there. When antibody formation is there, this is good for the patient and good for the physicians also. So mostly you can think of this as autoantibody response, and autoantibody response can be well controlled with the general immunosuppression. So this is the reason why even in normal general nephrology practice, patients coming with this factor H, anti-factor H antibody positive HUS, we are well managing with these patients with this corticosteroid or mycophenolate mofetil, patients are doing well. Little bit of initial plasmapheresis, do not have too much of the problem. So autoantibody response is good for both, for the patient and for us also. If it is there.
In the absence of, if the absence of antibody in such situation, will that place the patient under high risk, sir? CFHR1 and 3 in the absence of factor H antibodies.
I'm not so sure if CFHR1 to 3 gene mutations are actually directly associated. Maybe I'm wrong. But my reading into this is it's usually factor H, factor I, factor B. These are the factor B and factor C3 or gain of mutations. So per se CFHR1 to 3, because CFHR related proteins are not directly implicated in the activation of the complement system or restriction of the complement system. But sometimes they do form these hybrid genes where they may compete with factor H and block the ability of the factor H in sort of restricting the complement system. So that way, maybe there is a potential. But directly, I'm sure Dr. Narayan Prasad is better versed with this than me. That's my view on this.
Sir, one small question. Sir, with reference to the second patient who had a factor I deficiency, sir, the experience of transplanting such patients, anyway, we're going to start with eculizumab. When to stop eculizumab in this group of patients is the major question, sir, your experience and comments on that part, sir. Because this is the second patient is anticipating a transplant in the subsequent days, providing he has a suitable donor.
Factor I deficiency is always a very severe kind of things, and you have to very cautiously think of stopping whenever you want to stop eculizumab. Usually the recommended durations, whatever is there for about 2 years, 1.5 to 2 years, you have to be watchful. But without keeping in the mind that the patient will require, I will have the severe recurrence, we cannot go without.
But if he has a recurrence, then it has to be continued for lifelong. Huh? Suppose if you have recurrence after
if
stopping,
recurrence is there, then definitely you will have to continue.
Continue for lifelong. There is.
Yeah.
I want to compare this situation to camphor. So camphor is inherently flammable, but it doesn't sort of start the fire without a spark. And I think most of these, when they are in a stress-free period, they tend to be absolutely fine. But any trigger like the infection or whatever it is, I think is just going to make this whole thing burn. So this is purely, I think we got to be logical in terms of when we start and when we stop. And in some patients, obviously, we like, for example, C3 gain of mutation, you may have to continue forever. As opposed to CFI, which is considered to be moderate risk. I think it's just a bit of trial and error, I guess.
I think gain of mutation is always a very dangerous situation. And
Correct.
so we should always be very much cautiously, and it is possible that it may require for the longer period even for lifelong therapy. So definitely gain in mutation, we must be very cautious about this.
Okay, Dr. Narayan, so the final last question, just a practical question before winding up this session, because already we're getting time. What happens if you have a patient with the mutation is negative and still have a factor H levels are low in a patient suspected of atypical HS for going for a transplant? Mutation negative, factor H deficiency is documented. How to go about that if you don't have a mutation?
We can keep your eculizumab ready and go ahead with the transplantation without using eculizumab. That would be my suggestions. And most of the times you would be successful if factor H antibody is positive.
No, factor H deficiency is there, but mutation doesn't pick them.
Yeah, factor H deficiency is there, then definitely it is quite possible in that situations that you might have. Although this situation would be rare, what I guess, but if it is factor H deficiency there and there is no mutations, definitely we can go without giving eculizumab, but keep in mind that there might be the chance of the recurrence.
Yeah, we do see some patients, sir. Actually, 40% of them do not pick up mutations, but we do see some patients like this. That's why I asked. So thank you one and all for the.
So have you gone through the transplantation in this group?
No, we are still awaiting. Actually, we are skeptical of undergoing that. Actually, they are on one workup. Probably next month, we'll be planning for this kind of patient. One patient is there on lineup.
Yes, sometimes we should also see with some suspicions about these reports when we are getting from the metagenomes, and if there is something coming abnormal, you must ask to repeat it, the test, and see this. Really, many times we have sent back the samples, asked them to repeat these samples, getting the different results. So sometimes if it is not fitting into your clinical picture, must ask to redo. So because this is not always very easy from, because no doctors are sitting there, they have no capability to analyze the cases and everything. Yeah. Some scientist is doing that process, and sometimes the aberrant reports comes in. So we must ask him.
Okay. Thank you, sir. Thank you for the wonderful discussion on that. And let me not waste the time. And I asked Dr. Manjari Bhatt to share her slides to start the second presentations.
Yes, sir. Am I audible, sir?
Yeah. Go ahead. Make it short and quick so that we can have some useful discussions. Okay. Thank you.
Is
Yeah.
is the
Make
screen
it a
visible,
question.
sir?
Yeah. Go ahead, please.
Okay. A very good evening to you all. At the outset, I would like to thank the organizers, Dr. Rohan Augustine sir, Dr. Vishwanath sir, my HOD, and Dr. Fahad sir for giving me this opportunity to present an interesting case which we came across in our OPD, titled as A Silent Invader, A Lost Graft. So this is a story of a 46-year-old general surgeon hailing from Bellary. He is a deceased renal transplant recipient in October 2024, currently on maintenance hemodialysis weekly thrice due to graft loss. The story goes back to 2014 when he was diagnosed to have gouty arthritis of right great toe, and on evaluation he was detected to have hypertension and a serum creatinine of 2.4 milligram per deciliter. Urine routine had some proteinuria and RBCs. Underwent a renal biopsy. Biopsy was reported as IgA nephropathy. However, in spite of receiving 1 month of steroids, there was no significant improvement in the creatinine. Hence, he was continued on antiproteinuric measures. 9 years later, he progressed to end-stage renal disease and he was initiated via a right RC-AV fistula. Later on, he registered for a deceased renal transplant. After being on dialysis for about 1.5 years, he received a cadaver call on October 24, 2024 and underwent a transplantation. The donor was a 23-year-old female. It was a single vessel anastomosis with an ischemia time of 3 hours 38 minutes. Immediate post-transplant history, he was induced with 1.5 milligram per kg of ATG, achieved an Nadir creat of 0.9 milligram per deciliter by post-op day 4, and was discharged on post-op day 7 with triple immunosuppression and Valsite and Bactrim prophylaxis. However, on post-op day 10, that is 5th November 2024, our patient developed fever, chills, loose stools, dysuria, along with 3 to 5 episodes of gross hematuria. On examination, there was graft tenderness. Features of epididymo-orchitis was present. Creatinine, which was tested, was 1 milligram per deciliter. As possible etiology of graft pyelonephritis was considered, and he was started on IV meropenem and amikacin. Ultrasound showed bulky allograft with mild HUN, followed by a CT scan was done, which showed diffuse circumferential urinary bladder wall thickening with mild perivesical inflammatory changes. Subsequently, his urine culture and blood culture came back as no growth. In spite of being on antibiotics, he persisted to have on and off fever. There was episodic hematuria. His urine outputs were preserved about 2 to 2.5 liters per day. After about 3 to 5 days, he started developing fall in the total counts and thrombocytopenia. Slowly, his creatinine also started to inch up 1.5, 2.2, and 2.9. When the total count and platelets were falling, the dose of MMF were reduced, and subsequently he underwent an allograft biopsy. During the meantime, the CMV and BKV PCR which was sent came back as negative. So this was the biopsy finding. Glomeruli did not have any significant features. However, in the tubules, nuclear inclusions of viral infections in the form of nuclear enlargement, nuclear margination, and nucleolar prominence was seen. Plenty of neutrophilic infiltrates and comma-shaped histiocytes were distributed diffusely. Numerous intratubular granulomas were seen. Patchy areas of interstitial hemorrhage was noted, and areas of cortical necrosis was seen. IF was negative. IHC had less than 10% of PTC staining positivity for C4D. However, SV40, CMV, and adenovirus were negatively stained. Meanwhile, his urine adenovirus PCR came back as positive, that too more than 4 lakh copies per ml. Serum had more than 55,000 copies per ml. Now, how did we treat him? We initially reduced his immunosuppression. Tacrolimus was reduced to 1 milligram BD. MMF was stopped and Visalon was continued at 15 milligram per day. Antivirals in the form of Cidofovir for his renal creatinine clearance, 0.5 milligram per kg IV. A total of 5 doses were given along with probenecid, and IVIG, a cumulative dose of 40 grams were given. However, after starting Cidofovir, slowly his total counts and platelet started to fall, and ultimately he developed a pancytopenia picture, which was attributed to Cidofovir. And the creatinine also slowly started to inch up from 4 to 6.9, 7.7, and 9.8, along with drop in his urine output. Subsequently, when there was volume retention and the creatinine had gone up to 9.8, he was started on hemodialysis. Generally, pediatric transplantation and small bowel and liver transplant recipients are at a higher risk of acquiring this kind of adenovirus infection. ATG induction also is an important risk factor. However, in our patient, he received a very low dose, 1.5 milligram per kg. And a donor positive and recipient negative adenovirus status also is known to be a risk factor. However, in our patient, we did not know the baseline serology of the patient since we did not test him before the transplant. Generally, onset of the disease is within first 3 months in 75% of the patients, like how we came across in our patient, and 97% within 1 year. These are the common symptoms of adenoviral infection which can present. And in our patient, he had dysuria, he had fever, he had hematuria, sterile pyuria, also allograft dysfunction. Among the extrarenal common manifestations of adenoviral infection, our patient had features of orchitis, lymphopenia, gastroenteritis. Generally, apart from these, pneumonitis and hepatitis can also be seen. The treatment which is recommended for adenoviral infection is, if the disease is mild, that is the viral load is not too high and not multiple organs are involved, then just reducing the immunosuppression would suffice. That is MMF to be stopped, tacrolimus and steroids to be minimized. In case of moderate to severe disease, antivirals in the form of cidofovir, brincidofovir, ganciclovir and ribavirin, IVIG can be tried. Now, how do we monitor these patients? A PCR quantification of 1 log reduction within 2 to 3 weeks is considered a therapeutic response, and we monitor their serum creatinine, urine output, and CBC. Now, cidofovir is an antiviral of choice, which most of the literature tell. It is a viral DNA synthesis inhibitor. Cidofovir itself has got nephrotoxicity, and one more side effect is neutropenia. To reduce the nephrotoxicity, it is suggested to aggressively hydrate the patient, that is 1 liter of NS 1 to 2 hours before infusion and 1 liter during or immediately after the infusion is suggested. And to prevent the proximal tubular toxicity, administration of probenecid along with cidofovir is recommended. That is, it's an oral tablet, 2 gram oral 3 hours prior and 1 gram 2 hours and 8 hours after the infusion. Generally, if the patient is having a normal renal function and the dose suggested is 5 milligram per kg once a week for 2 weeks as induction, followed by 5 milligram per kg every 2 weeks as per the response. However, once the creatinine clearance reduces, there is dose modification accordingly. Now, the story of our patient continues. After about 1 to 1.5 months of treatment with cidofovir, the serum adenovirus PCR levels came down 1400. However, there was no improvement in the creatinine. The pre-hemodialysis creatinine was 10. He had a residual urine output of only 300 to 400 ml. Hence, he required maintenance hemodialysis weekly twice. Immunosuppression wise, tacrolimus was continued at a very low dose, 1 milligrams BD, and the levels were maintained at 5 to 7. Everolimus was added, and Visalon also was continued at 10 milligrams a day. Because of no recovery in the creatinine and urine output, he underwent a second allograft biopsy 3 months, around 4 months after the transplantation. That the second allograft biopsy suggested features of acute cell-mediated rejection, which was plasma cell-rich type, and features of background adenovirus nephropathy was present. However, the severity of adenovirus nephropathy was not as severe as the first biopsy. Now, events post this biopsy, subsequently over the next 1 month, patient developed severe graft pyelonephritis with sepsis and septic shock, during which his immunosuppression had to be reduced and later on stopped. He recovered from this and subsequently after 2 months developed acute element type of quadriparesis, proximal more than distal muscles, diagnosed as Guillain-Barré syndrome, was treated with IVIG 2 gram per kg over 5 days. Again, after 1 month, developed herpes zoster at the level of T4, T5 dermatome, treated with valcyclovir. However, developed valcyclovir-induced neurotoxicity, subsequently switched over to acyclovir. Currently, he is on weekly 3 times hemodialysis, recovered from quadriparesis. Latest adenovirus copies, which was repeated last year, was 174 copies per ml. He has come to our OPD with the big question of second transplantation. The question is, can he? Now, first, we should ensure a complete virological clearance with adenovirus PCR in blood, preferably in urine also, should be negative at least twice, 2 to 4 weeks apart. Even though it is negative, there is always a risk of latency in such viruses. Second would be a waiting period. Though there is no fixed guidelines recommended, at least 6 to 1 year should be the waiting period. Third, pre-transplant, we should ensure that there is no active infection. Fourth would be the immunosuppression strategy. Our patient with the second transplant itself will belong to a high-risk transplant, and preferably an ABO compatible and HLA compatible donor should be selected, and basiliximab induction over ATG should be preferred. Third, always counsel the patient about risk of reinfection and recurrence, especially with high immunosuppression and incomplete virological clearance. Now, this is a paper which was published showing the outcomes of adenovirus infection in kidney transplant recipients in Mayo Clinic. About 11,000 kidney transplant patients were reviewed, and among them, 17 of them had symptomatic adenoviral infection. 53%, that is 9 out of 17 patients had a graft loss. 53%, 9 out of 17 of them had post-adenoviral rejection. 2 of them had transplant nephropathy. The median time from transplant to infection in this group was 30 weeks, and 35% of them received only IVIG, and 29% of them received both IVIG and cidofovir. So even though the incidence of adenoviral infection in transplant patients are quite low, but the effect might be deleterious. Now, BKV virus and adenovirus are both very common viruses which cause hemorrhagic cystitis in post-transplant patients. Typically, what we know is BKV virus tends to infect the patient 3 to 12 months post-transplant, and the median time from transplant is told as 9 months. Adenovirus typically occurs a bit earlier, less than 6 months. Risk factors for both BKV and adenovirus remains the same. In the clinical manifestation, BKV virus, generally we see a gradual rise in creatinine, and they will not have any systemic symptoms. However, in adenovirus, there is an acute rise in the creatinine and associated with the systemic symptoms. Typically, decoy cells are seen in BKV nephropathy. Histologically, a necrotizing interstitial nephritis and areas of hemorrhages and areas of cortical necrosis, like how we saw in our patient, are typical features of adenovirus infection. However, SV40 staining and basophilic inclusions are typically seen in BKV nephropathy. Now, outcomes, BKV will generally have a chronic course, whereas in adeno, if the disease is mild, then we can expect a good recovery. But if moderate to severe, then it can be a fulminant course, like how we saw in our patient. Thank you, sir.
Thank you, Dr. Manjari, for the good presentation, neat and clean presentations. And Dr. Faghat, your consultant, can you have your short comments, please, so that we can pass the comments to panelists?
Thank you, sir. At the outset, congratulations, Manjari, on the brilliant presentation, and thanks to the organizing team again for giving our unit this opportunity to present this challenging case. A few highlights, I think, as Manjari clearly pointed out, the presence of the thickened bladder wall as well as the presence of hematuria in the post-transplant setting with cultures negative was one of the red flags which did alert us to work up and quickly biopsy and look for adenovirus. Subsequently, while the patient was on treatment with the cidofovir, there was allograft dysfunction and there was a dilemma whether this is due to the adenovirus associated nephropathy itself or cidofovir induced drug toxicity. So, if the house can shed some light on how differently they would have managed the case, and the pressing question about the second transplant, and considering the fact that the first transplant was a cadaver transplant, but the cumulative ATG that was given was around 1.75 milligram per kg. Even if we get we have an ABO compatible and HLA compatible donor for the second transplant, considering the fact that second transplant itself would render an increased immunosuppression, what would be the approach of the house be for this case?
Dr. Narayan, thank you, Dr. Faghat, for your... Dr. Narayan, your quick comments.
Yeah, really, this was a brilliant presentation by Dr. Manjari, and this is a good case, a good learning for all of us. Really, the things we encountered such kind of the patients and off and on in a year time, and so it is an uncommon presentation. As expected, it was more commonly we see the bacterial pyelonephritis kind of presentation. You might have the similar symptoms also, but urine culture negativity, blood culture negativity was showing that something else is happening, and rightly pointed out, it was looking like interstitial changes in the bladder wall might be leading to the refractory kind of the hematuria going on. So that was the red flag sign from there. Only thing, only one my comment is there that many times these viruses do not dissipate even with this you are using these antiviral agents very severely. So when there was graft was deteriorating, graft function was deteriorating, reducing immunosuppressants, many times the virus gets clear. So it is quite possible, but in this situation, I do not know, even now the virus is persisting. So in this case, it might be the different scenario, but usually if you feel that the drug is nephrotoxic and causing this much of the graft dysfunction, at least there is temporal association of the graft deteriorations with this use of the cidofovir. So clinician will think of probably this is happening because of the cidofovir rather than adenovirus is causing this much of the injury. So little different, I might have done stopped the cidofovir and reduce immunosuppressants, let whether this periodic checkup of the viruses, whether this is going down or not with the reduction of the immunosuppression. So that might work or might not work. So definitely, because many times we see recently we have some parvovirus infection, very refractory, not responding to anything. But in 1 year, 2 years of the time, now it got cleared, automatically got cleared when you have reduced immunosuppression. So this happens, this is the response of the many of the viruses, particularly in the post-transplant period. So that was the only difference. And as far as concern of the second transplantation is there, definitely if the presentation was so severe, we like to have this virus go off. Latency in this virus is very common. It is quite possible after this aggressive immunosuppressants may come back, or many times you see the virus does not come back also. So just to wait for and see that whether this virus, at least the active replication of the virus go off, and then we can go for the transplantation with all precautions as rightly pointed out instead of antithymocyte giving the basiliximab kind of inductions, keeping the dose towards the lower side. One thing is always there that if virus is replicating in the body, probably your patient is very highly immunosuppressed. So clinical assumption should be like that rather than giving the aggressive immunosuppression. The lower dose of immunosuppression can go up. Definitely, some of the viruses are immunomodulatory. Can some viruses cause precipitate rejections like the CMV? But most of the times, if the virus replication is in the body, they think of your patient is immunosuppressed. So whether it also depends on whether the patient is still on thinking of the second transplantation is still on immunosuppression, or you have make it off immunosuppression. So that is also other important aspects. If continue thinking of that, there would be more of appearance of the donor-specific antibody after stopping complete immunosuppressions. Some units continue giving this. So that might also alter. If you can, if it is not clearing now, we can completely stop immunosuppression and see this whether the virus clears or not.
Great.
Yes.
Yes. Sir, you are. Okay, go ahead,
Completely off immunosuppression, sir. Some Vislon 5 mg OD he's taking. Apart from that, he's not on any immunosuppressive medications.
Okay. That's where we can wait for sometimes it might get clear.
Yes.
Dr. Nara, actually one small interesting question. You will be your center is being in that transplant factory. You're doing a lot of transplant. What is the incidence of adenovirus nephropathy in your center?
Very uncommon. I think hardly we have encountered 4 or 5 cases over this 15-20 years. So it is uncommon kind of the presentations, but definitely when you are struggling with this, why this is happening, then only you come out with this kind of suspicion. So high index of suspicion in such group of the patient who are not responding to the common drugs, or you are not able to isolate any common pathogens. Definitely we should think of, we are running somewhere. Many times we have adenovirus after getting this kidney biopsy. When graft biopsy done, then some inclusion body came out of like this adenovirus. So it is quite possible, but uncommon kind of events.
Dr. Pani, your comments, please.
Yeah, I think it's a very clear presentation of Manjari. It's great. A couple of comments are, obviously, this guy seems to have been over immunosuppressed, despite him receiving very modest dose of ATG. So he had obviously the adenovirus, he had herpes zoster recurrence. This all suggests to some T cell dysfunction in a way. And the minimal dose of ATG is also depleting his T cell function more than what is anticipated. I wonder what's the role of TOC-tenovirus in these situations in terms of monitoring? I mean, now that we already burned our fingers, whether for the future, I mean, obviously this data is still, I mean, not robust enough for us to use this in the clinical arena, but whether sequentially following up the TOC-tenovirus, whether in the unimmunosuppressed state, if his TTV levels are going to be much higher than the agreed baseline, that sort of reflects a T cell dysfunction for this gentleman. And in such case, I think, as you have rightly pointed out, avoiding T cell depleting agents like ATG would be beneficial. And further, keeping him on low dose of TAC, because TAC has got more effect on the T cells, may be also considered. And once the acute phase of the wound and everything has been healed, considering low-dose TAC and everolimus is something which may be beneficial. I mean, these are all just hypotheses and nothing is proven, but just had a thought, these are interesting points to discuss.
Thank you. Dr. Pani, most of the time what we fault is actually over reduction of immunosuppression. Most of the time we land up with rejection in this kind of a DKV or adenovirus and all. Right. And we should be, but knee-jerk, like we'll be stopping MMF suddenly, and suddenly we see the patients going for rejection. And that time point, we cannot do anything at all. So graded immunosuppression, what we suggest is graded immunosuppression. Look for the response. Don't be fast in reducing the immunosuppression so fast. And the chance of, again, sirolimus and everolimus and tacrolimus combination, most of the time I find that rejection rates are very high compared to your traditional MMF steroids and tacrolimus.
So I think
yeah.
Sorry, go on.
I've dealt 2 cases of adenovirus nephropathy, and I didn't use Sidofovir. Touch wood, that patient recovered well with the minimal reduction of MMF and tacrolimus. With the use of IVIG, I could able to pull out the patient from that, and still the adenovirus PCR is negative, and the graft function is holding in around 1.5 to 2. That time presentation was very severe, and even went to encephalopathy. Rarely encephalitis and adenovirus encephalitis also reported. And this patient required dialysis, and subsequently he came out of that and now maintaining good. So it's all depend upon how the patient responds, how your cells are responding. And it's easy to say that your immunosuppression do like that. And it's all depends upon the patient's profile, I think so. And
Absolutely. Absolutely right in that in these situations, obviously the priority is the life of the patient and then the kidney. And in a situation, I mean, from the retrospective analysis data that you showed, almost 25% of the patients died. That's a pretty high number for us to cope with. And in such situations, as you rightly said, it has to be tailored for individual, and we have to be choosy in terms of how we use. And I mean, not with adenovirus, but similar to this, like BK and parvovirus, there were situations where I have maintained them on low-dose TAC and everolimus with frequent IVIG. Managed to bring both of them out, and also subsequent testing to see if they developed any antibodies, and they were negative. So I think a combination of low-dose multiple agents is something could also be considered. Like if we're very worried about low-dose TAC, then there is one patient where I had put them on quadruple therapy of low-dose TAC, low-dose mycophenolate, and low-dose everolimus, along with a little bit of steroid. But everything like cyclosporine is like 40, less than 50, mycophenolate 180 BD, everolimus levels of around 2 or 3. So sometimes we do end up doing strange things, whether this is based on facts, data, or experience, or gut instincts. I don't think we can clearly say which is the right way to go ahead.
Thank you. And already we have exceeded our time of time. And thank you for the good discussions. And take-home points are there in the first case of atypical HUS. They do get away with CFH mutation with the eculizumab on the day of transplant and at the time of discharge. And it was rosy to see that, but it was not in all the cases. And need to have a good counseling with the patients regarding the outcome before proceeding these cases of atypical HUS, what I feel like. And maintaining the tackle around the 5 to 7 is another good point was suggested at the time of discussions. And regarding the second case and adenovirus nephropathy, and timely reduction of immunosuppression and even withdrawal of MMF and the addition of your Sidofovir and IVIG will do good for it. And again, the patient developing rejections or not, it depends upon the individual's profile, and you cannot do anything much more than that. But the standard treatment protocol has to be followed for all these kind of viral infections. And once again, we like to thank the panelists for the excellent discussions for those 2 cases. And Dr. Narayan Prasad and Dr. Pani Gopalani, thank you for being with us and enlightening us with your discussion. And I'd like to thank the speakers who take a lot of effort in preparing the slides and presenting to us, Dr. Shaktiram and Dr. Manjari Bhatt, and ably assisted by the mentors. And of course, the delegates who have attended this meeting, and thanks for your wonderful support, and the MQ team for providing the technical platform. And thank you one and all for a good evening. And we have much more to cherish with these 2 cases. And it is a very good, actually, this atypical HUS, where a lot of things are coming out, and many nuances are there in handling these patients, because initially it was thought that it was non-transplantable, and now it is becoming a transplantable disease. And thanks for this discussion would have given some light into the guts of doing a transplant in atypical HUS. And thank you one and all for joining us for this meet. And we will meet in the next month, first Saturday. And we request all the institutes to present some interesting cases so that we can learn each other and we can grow each other. And ultimately, the benefit should be the patients. And with a large EGSR pool and a limited transplant, and we should be very careful, and we should be knowledgeable, and we should have a good, thorough knowledge about transplant before proceeding. Thank you very much for joining this. Thank you.
Thank you very much.
Thank you.